Hello, and welcome to Diabetes Deep Dives. My name is Candice, and I am from Diabetes Canada. I'm so pleased that you are joining us today. Diabetes Deep Dives is a series of videos designed to dive deeper and beyond the surface of different areas of diabetes management. We're exploring those burning questions you may have by featuring dynamic and engaging guests with knowledge or lived experience on the topic. Our goal is to share information in ways that will spark continued interest and learning and leave you with practical tips and tools that you can easily use. We'll be dropping a new video every month, so subscribe to our YouTube channel and click on the notification bell to be notified about new content. You can also check us out on social media to find out when the next one will be posted on our YouTube channel. Just a reminder that the information shared in these videos in no way replaces the advice and direction that you have from your healthcare team. If you have questions about your care, please speak to your healthcare provider and team to make sure that you are getting the best advice. In this video, we are going to hear from Dr. Alice Cheng about the intersection between type 1 diabetes, menopause, and sexual health. We know that diabetes and sexual health are not topics that everyone talks about, so we are happy and excited for this discussion. Dr. Cheng is an endocrinologist at Trillium Health Partners and Unity Health Toronto, as well as an associate professor at the University of Toronto. She has been involved in the development of the Diabetes Clinical Practice Guidelines since 2003. In this video, Dr. Cheng discusses the hormones involved in menstruation, perimenopause, and menopause, how these hormones affect living with diabetes, other health concerns related to menopause, and how that impacts diabetes management, and tips for living well during menopause and beyond. We hope that you find this discussion enlightening and that it helps you to successfully manage your journey with diabetes. And now over to Dr. Cheng.
Welcome everyone to this presentation entitled Menopause in Type 1 Diabetes, What to Expect and What You Can Do, presented by Diabetes Canada. My name is Dr. Alice Cheng, an endocrinologist from the University of Toronto, and it is my pleasure today to be sharing this information with you. Now, if we think about the hormonal stages of life, particularly in women, we think about things such as puberty, pregnancy, perimenopause, and menopause. These are the hormonal stages that a woman may go through over the course of her lifetime. Now, in all of these stages, a common theme is that the hormones are changing. So the question then becomes, how do hormones, sex hormones in particular, affect diabetes? Well, to answer that, let's think about the menstrual cycle. I'm going to take you back to biology class from high school to remind you about the hormones involved in the menstrual cycle occurring in the first place. So here on the diagram on the right, you'll see on the top two hormones listed, LH and FSH. Those are the pituitary hormones, the hormones that are coming from the brain to help sort of mastermind the entire cycle. The middle chunk is looking at estradiol and progesterone, which are estrogen and progesterone, which are hormones that come from the ovaries, which is also very important in the cycling that occurs. Now, day one of the cycle is actually the first day of bleeding. And if we start at day one, you'll notice in the middle panel that the red line, the estradiol, starts to rise over time. And that rise over time is triggered by changes in FSH and LH in the pituitary. And that rise in estradiol happens slowly over time. And then suddenly, around just before day 14, there's a surge in the estradiol and a surge in LH. And that surge results in ovulation. So ovulation is the popping out of the egg. Once the egg has popped out, the remaining cells where the egg used to be in the ovary starts to transform and starts making a hormone known as progesterone, as shown here in the orange dotted line, and the progesterone levels start to rise after ovulation. The progesterone hormone is responsible for the PMS symptoms that we experience before a period. Now, those cells that are making progesterone only live for 14 days. So 14 days after the egg has been released and those cells start making progesterone, 14 days later, those cells die. And when the cells die, the progesterone level drops. And that drop in progesterone level is what triggers the bleeding to occur. So in the first phase of the cycle, what's deemed the follicular phase, what's happening is that the estrogen levels are rising slowly, and that's building the lining of the uterus in preparation for potential pregnancy. And then once progesterone is made after ovulation, progesterone doesn't build the lining, progesterone matures the lining, prepares it for potential embedding of an embryo. But then 14 days later, if it's not used, the drop in progesterone allows the shedding of that lining to occur. So this is the menstrual cycle, a reminder from high school biology class. Follicular phase is the first half of the cycle. The middle is ovulation for a day, and then you've got the luteal phase, which is the phase with high progesterone. Okay, so therefore, how does this impact the glucose levels? Well, there's a gradual increase in estrogen in that follicular phase, which actually raises insulin resistance. So you become more resistant to insulin slowly in that first half of the cycle. But once progesterone starts to rise, it's a very insulin resistant hormone, and you find that your blood sugars tend to go higher and you need to give yourself more insulin. But once that drop in progesterone occurs, which triggers shedding of the lining or your period, then that drop in insulin resistance means that you suddenly become more sensitive to insulin and your insulin requirements go down. So this is what the pattern that I'm sure many of you have observed yourself with respect to your cycle. So then therefore the impact on blood glucose is obviously different depending on what part of the cycle that you're in. But the time period just before your period tends to be when your sugars are the highest. And that could be just 3 days before, or for some ladies, it's up to 10 days or even 14 days before their period. So as soon as the progesterone starts to go up, they start to notice an impact on their blood sugars. However, once the period starts, then there's an abrupt drop in the blood glucose levels, which of course have to be accounted for. So from an insulin dose adjustment perspective, during the PMS time, which is the time when the progesterone levels are rising, not only is it giving you insulin resistance, but I think many of us can attest to the fact that there are also cravings for food that may occur, particularly carbohydrates. So therefore, one needs to account for that, of course, when you're carb counting. And then also there needs to be an increase in the insulin. And for those who are very regular, you can actually predict that and have a different basal program, for example, for those of you on a pump, to be able to account for that period of time. And then you have to change that basal setting once the period starts. So that's when you're cycling regularly. But what happens in perimenopause and in menopause? So I'm going to direct you to a fabulous website called menopauseandyou.ca, which is actually created by the Society of Obstetricians and Gynecologists of Canada. So a very credible source, well-designed website, designed for people, the general public, and gives really up-to-date expert advice on menopause in terms of definitions and potential treatments, et cetera, et cetera. So a great place to help guide you for any questions that you may have. So what exactly is menopause? So menopause is technically a clinical definition based on not having a period for 12 months. Now, from a blood test perspective, what you could identify is an elevated FSH, which is one of the hormones that comes from the pituitary. And the FSH is high in response to low estrogen from the ovaries that are pooping out and no longer working because they've run out of eggs. And the official diagnosis of menopause, though, is having no period for 12 months. And with that can come a high FSH. 95% of the time, it happens after the age of 45, and the average age is around 51 in North America. But leading up to menopause, there is a time period known as perimenopause. Perimenopause is usually in your 40s and is associated with, and this is the visual that I use in my head, and when I'm explaining it to my patients, just imagine it's like your ovaries are like a car running out of gas and it's sort of sputtering. So every now and then it pops out an egg, but it's not doing it in a regular fashion like it did previously. And therefore your periods are just unpredictable. They could happen 2 months later, they could happen 6 weeks, they could happen 2 weeks. So it could be shorter, it could be longer. It's just no longer the regular cycle that many of you may have had previously. which also means that during that time, it becomes harder to predict when a period is going to show up and your hormones are doing funny things. And it's just a potentially difficult time for many women. And there are symptoms associated with those changes in hormones. So there are potential menopausal / perimenopausal symptoms. And this is taken from the Menopause and You website. And I hate to share this part of the information with you, but these symptoms can last between 6 months up to 15 years, depending on the individual. And the symptoms are shown for you here in the red box. The most common one that we tend to hear about, of course, is hot flashes, night sweats. However, there are other things such as sleep disturbances, which can be quite common. Fatigue is another one that people may describe, just not thinking as clearly as they previously did. Some people can get mood swings, joint aches and pains. I mean, there's a variety of symptoms that can come with the perimenopause / menopause, and it's usually a result of just fluctuating hormones and that reduction in estradiol or estrogen overall, as well as the loss of progesterone. Now, the challenge in diabetes is that the irregular menstrual cycles makes it very difficult for you to predict what your blood sugars are going to do. Whereas when your periods were regular, you were able to say, okay, checking my calendar, this is about the time when I'm going to need to increase my insulin. But then in the perimenopause, because you cannot predict when your period's going to show up, it's going to be harder to do that prediction. The other thing is hot flashes become very difficult to differentiate from low blood sugar or hypoglycemia. And that becomes a confusing aspect as well. So what can you do about it? It's just check a lot. Frequent monitoring of blood glucose is going to be your best way, certainly, to differentiate vasomotor symptoms of hot flashes with that of a low blood sugar. Continuous glucose monitoring may be particularly helpful during this period of time when things are just wonky and you need to be able to make adjustments in a fairly quick manner. Increase insulin doses or reduce insulin doses as needed based on what's happening with your sugars. And then living healthy, so regular physical activity, eating healthy, all of these things can certainly help lessen some of those perimenopausal symptoms, but it definitely is difficult to address. Hormone replacement therapy is, of course, on the table for those women who suffer a lot from perimenopausal / menopausal symptoms. And when I say suffer a lot, meaning it's affecting their quality of life, affecting their ability to function, then hormone replacement therapy is something that could be discussed with your physician. And certainly someone living with diabetes could still take it. This would be the same advice we would give any woman who's having significant perimenopausal symptoms. And that could come in the form of low-dose birth control, or it could come in the form of low-dose hormone replacement therapy, as we might use in menopause itself. And then what about menopause and diabetes? So that's sort of perimenopause and the symptoms that can go with it. But once it's menopause, and there's been no period for 12 months, the only good thing is that the hormonal fluctuations of the unpredictable cycles, there's no longer an issue. So at least from that perspective, things are stable. However, you may still experience hot flashes for many years to come, and that is still hard to differentiate from hypoglycemia, and therefore frequent testing is necessary. As well, some women may find over the course of perimenopause into menopause a weight gain, or it's harder to lose weight. So with weight changes, that could also impact your insulin resistance. So again, the main strategy is frequent testing of the sugars and being aware of what might happen. The other thing with menopause, though, is to remember other health issues that may come independent of diabetes with menopause. So asking about getting your bone mineral density testing, checking for osteoporosis, making sure you're getting proper mammograms based on approved timings to rule out any breast masses or breast cancer, and also recognizing that cardiovascular risk factor control is critical throughout your life of diabetes, but particularly as you enter menopause, because one is older at that time. So making sure that things like blood pressure and cholesterol are well controlled, that you're not smoking, and then, of course, again, the healthy lifestyle and the body weight. But in terms of treatment of menopause itself, it's no different for those with diabetes and without. So if hormone replacement therapy is right for you and it's a discussion you've had with your team, then by all means, you can go ahead and use it. It may impact your blood sugars because, again, that treatment will involve estrogen and progesterone, but now you know how those two hormones can impact your blood sugars, and then you can just check and adjust your insulin requirements accordingly. But what about sexual function? Because that's the other aspect that can certainly change in the context of menopause, but frankly, even before menopause, sexual function and female sexual dysfunction is more common than perhaps we realize. So if we think about female sexual dysfunction, these are some of the statistics that are out there in terms of how common it can occur. And it's common, as you can see here. And these can be grouped into things like hypoactive sexual desire disorder, female arousal disorder, orgasmic disorder, or sexual pain disorder. So this is referring to the different phases of the sexual response that a woman may have. Now, specifically in diabetes, though, female sexual dysfunction may be common because of other things that can come with diabetes that can, of course, impact sexual function. So if there are blockages in arteries, that could affect circulation. If there is damage to nervous system, then that could reduce sensation. High blood sugars can reduce lubrication, can result in yeast infections, which of course would not be very pleasant from a sexual function perspective. There may be issues around body image or fear of hypoglycemia. And then of course, the mental health aspects are critical in diabetes, and depression and anxiety can obviously impact sexual function. And then there may be medications that some are using, not necessarily specific to diabetes, but other medications that can impact sexual function. But what about specific to menopause? Well, specific to menopause, the two big ones that often come up is vaginal dryness or reduced sex drive. Now, strategies to address this. So hormone replacement therapy is probably one of the best strategies to address the vaginal dryness. And that could be just local treatment. So vaginal creams that could then reintroduce some estrogen to the vaginal wall, which would then help with lubrication and avoid the dryness, or perhaps systemic treatment, pills, if hot flashes and other systemic symptoms are a major issue. Of course, lubricants would be very useful to make the sexual experience more enjoyable. And again, the usual motherhood statements of regular physical activity and lifestyle interventions, just giving you more energy and feeling good about yourself, and those endorphins and just feeling happy overall is obviously going to also be helpful for sexual function. Now, in terms of the reduced sex drive, I mean, the female sex drive is very complicated. It would be like looking at the cockpit of an airplane. And there are multiple components. There's the biological, there's the psychological, there's the social, and there's also the contextual. So it's not as simple as replace a hormone and boom, the sex drive is back. So when there is reduced sex drive, it's important to determine all the things that may in fact be affecting that. There could also be an official diagnosis of something called hypoactive sexual desire disorder, which is officially defined as an absence of sexual fantasies, absence of desire for sexual activity, but very importantly, causing distress in a minimum of 6 months. Many women may experience the first two, but it doesn't really bother them. It doesn't bother their partner. Well, in that case, it's not a disorder. However, if it is causing distress and it is chronic, then this could be defined as hypoactive sexual desire disorder. And there actually is this screener that exists online that you could look for, where if you answer yes to the first 4 questions, but more importantly, no to the question number 5, then it could be diagnosed as generalized hypoactive sexual desire disorder. And the no to number 5 is important. So it needs to not be secondary to a recent operation, mental health considerations, medications, pregnancy, et cetera, et cetera, et cetera. So it needs to not have another explanation. Then in that case, it could be defined as hypoactive sexual desire disorder. But what are the strategies to address reduced libido, whether it's in the form of HSDD or just generally speaking, reduced libido? I think discussing it with your healthcare team is important because there may be certain tests that need to be done to rule out other causes. If the thyroid's not working properly, if the blood sugars are very high, if there are psychosocial things that are going on that are impacting it, then all of those things could potentially be treated or reversible. So it's important to check out other potential causes. And then if there's not much to find, then cognitive behavioral therapy can be very helpful. Sex therapy can be helpful. And of course, things like vaginal lubricants, because painful sex is obviously not going to be enjoyable. And then only in those who are postmenopausal women, then testosterone low dose could be considered if it's officially diagnosed as hypoactive sexual desire disorder. So to summarize, hormones affect diabetes a lot. And we went through the menstrual cycle, and a reminder that there's an increase in insulin requirements, particularly for the up to 2 weeks prior to a period. But the perimenopause then is that transition time when things are fluctuating considerably, and that's also when symptoms can be quite strong. And therefore, the only strategy you really have is to test a lot and then to adjust your insulin accordingly. To smooth things out, one can try things like low-dose birth control pills or low-dose hormone replacement therapy. But again, that's a discussion with your team to see if it's appropriate for you. It's the same discussion we would have with any woman, even outside of diabetes, and the presence of diabetes would not exclude you. So of course, you could use those if necessary. Menopause is officially no period for 12 months. And at that point, make sure that you're considering other things that can come with age, which would be checking for osteoporosis, ensuring that your cardiovascular health is well managed, and of course, mammograms to screen for breast cancer. And then finally, sexual dysfunction is an issue that women may have even before menopause, but certainly with menopause, and is an important discussion to have with your healthcare team. So thank you very much for your kind attention, and I hope that this presentation was useful for you.
Thank you so much for joining us to dive deeper into diabetes and menopause. Please take the opportunity to let us know what you learned, what you liked, and how we can do better in the comments section below. If you have ideas for other topics you'd like to learn more about, you can include that in your comments as well. If you are looking for more resources about diabetes management, please visit our website at diabetes.ca. You can also email us at info@diabetes.ca or call our info line at 1-800-BANTING. That's 1-800-226-8464, and speak to one of our information and support specialists who can address your needs. Thanks again for joining us, and see you next time.